Next is the keynote talk of the session. As Manoj sir rightly pointed out, we are very lucky to have Dr. Parakesh Shah over here. As sir needs no introduction, I would like to say a few words about sir. Sir has graduated from Aravind Eye Hospital, Madurai. After completing his fellowship, he is working as a consultant in Retina Department of Aravind Eye Hospital, Coimbatore, and has developed the pediatric retina and ocular oncology service over there. Sir's main areas of interest are retinopathy of prematurity, retinoblastoma, and intraocular tumors. Over to you, sir.
Good morning, and thank you very much. At the outset, I'd like to thank Dr. Sheera, Dr. Manoj, and the KSOS for inviting me here. And I'll be talking about the surgical management of ROP. So I have no financial disclosures. So vitrectomy for ROP is one of the most challenging problems facing the vitreoretinal surgeons, and we feel this is the ultimate thing to do. But frankly, it is one of the easiest to do. It is much easier to do and compared to an adult if done properly. And why is it easy? Because what you have to do for a lens-sparing vitrectomy or any ROP surgery is just do a good core vitrectomy. And just to tackle the traction bands. The traction bands are the lens to the ridge to ridge, ridge to periphery, and the ridge to disc. So this is what all you have to do a good ROP surgery. There is no need for doing any PVD induction, and there is no need to do any vitreous base shaving as we do in the adult for all the cases. Now, why is it difficult compared to the adults? It's just because of the space constraint. The ceiling is down, that means the lens is down, the retina is lifted, the eye is short. So it's a really tight space where you have to go and tackle this problem. Like I said, the lens occupies almost 25 to 30% of the space, and this restricts the intraocular manipulation. And the retina also is elevated, and with a shorter axial length, the space is very, very tight there. So the axial length of the newborn child is only 16.5 compared to 24 for an adult. The vitreous volume is also 1/3. And the ciliary body is actually, there is no sort of short planar existence. It's actually through a the plicator. So it's an entry through the pars plicator. And that is why your entry should be anterior, not as posterior as you see in the adults. And so this table shows that what your entry site should be for any intravitreal injections or even for ROP surgery, and this is according to the age. So we usually take 1.5 millimeter from the limbus for all the ROP surgeries, be it injection or for sclerotomies for lens-sparing vitrectomy. And as the age grows, you can keep on going a little bit further away, and by the age of 7 years of age, you can safely go and use the adult techniques. Now, what are the indications of surgery in ROP? So obviously detachment of 4A, 4B, or 4-5 or stage 5, but not that all of these require treatment. So when will you operate a 4A? Only when it's vascularly active and it's more than 6 clock hours. But if you see a child with a 4A or 4B that who is like more than 6 months of age, it's stabilized, there's no actually really need to do a surgery. 4B also if it's only vascularly active, and stage 5. Now the timing, the previous speakers mentioned, the phase 1 of ROP starts as soon as the child is born. Phase 2 kicks in by around 32 weeks. And the treatable ROP comes by around 35 to 37 weeks. So it's only around due date, like 40 to 42 weeks, when the VEGF levels drop and the transforming growth factor beta, the TGF-B levels increase. And that is the ideal time to do surgery, because the traction, the VEGF is less, and the traction is the sort of at the peak there, and that is the time you would want to operate these babies. Pre-operative evaluation, obviously anesthetic fitness is required, mandatory, and you have to have a NICU backup. We are in a standalone eye hospital. We don't have NICUs. So we make sure that the adjoining hospital neonatologist has seen the baby, given the fitness, and post-operatively we send the child there for a 1 day for in case any complications arises. Education of the parents, the visual expectations, what you have to tell them is, especially for a 5 or a 4B, that the child is never going to see a normal vision like what we see. The expectation should be like, the stage 5 can get a little better. Stage 4B is always going to be stage 4B. And even if it settles, there's going to be RP degeneration, the visual outcome is not bad. I mean, it's not going to be very good. And 4A also, you have to be very cautious in telling them that take the risk and the benefit. Always the risk, anesthesia risk is there. You explain to them, anything can happen. All these babies are usually through IVF. They are all sort of, what do you call this, the late pregnancies and precious deliveries. So last thing we want any complication happening because of anesthesia. So you have to really tell them and counsel them. Do an ultrasound, especially for a stage, even for stage 4A and 4B, you would actually get the traction bands where it's maximally present. And before starting the case, it's mandatory to do a good indirect ophthalmoscopy, so that will make you plan where do you put your sclerotomies. In adults, like it just can't go by the rule of thumb that inferotemporal, I'm going to put my infusion, and the superior two will be the sclerotomies for the light probe and the vitrectomy. It changes case by case. So the surgical options are for stage 4 is scleral buccal or the lens-sparing vitrectomy. Lens-sparing vitrectomy is what is preferred. And 5 is lensectomy vitrectomy and open sky vitrectomy. Of course, lensectomy vitrectomy is preferred. Scleral buccal, although easy, it causes a lot of anisometropia and amblyopia issues. And if it's a posterior traction, then the buccal is not really going to help in tackling that. So these are some surgeries of the lens-sparing vitrectomy, how it is evolved from 20 gauge to 23 gauge and 25 gauge and now 27 gauge. So all this may look very flashy, but the principle is the same. Whatever gauge you use, it is the same. You go 1.5 millimeter from the limbus and you just go and tackle the traction bands. The only difference is in 20 and 25, you do a transconjunctival, you have to do a peritomy, whereas 25 and 27 gauge, you can do a transconjunctival also, what you do in the adults. And at the end of the day, it doesn't matter which gauge you use, but your idea should be easy, that you just have to go down, cut the traction bands and come out. And it's always safe to put the sutures, even if you're going at 27 gauge or a 25 gauge. And it's always safe because you can't go back if it's hypotony next day and give the general anesthesia again. A few modifications which we have used in the previously is the trichode assisted vitrectomy. It's very helpful because it just shows you can go very close to the retina and cut the vitreous very close to it, and that is what the aim should be. But the problem here is that the trichode gets stuck so well, it's impossible to remove it, and we have had issues of a few cases going secondary glaucoma in the postoperative period. So now that is what, now we have stopped using it. Now these trocars and cannulas, what the company gives is for adults. For pediatric, it's very short. So what we use is we make a small spacer before inserting the cannulas inside the eye. And this is a 42 gauge, 42 band, which we cut into small cubes. And we pass the trocar and the cannula through it first for all the three. And then we insert it into the eye, 1.5 millimeter from the limbus. So what happens is it's around 1.5 to 1 millimeter thickness. So it effectively reduces the intraocular part of the cannula, and that saves us from getting a lens touch. And sometimes the traction is so anterior that if that cannula is too deep, you may not be able to assess it. So we are in the process of developing a pediatric trocar cannula with our Aurolab company, but this is something which we have tried, but it's still not out. These are some of the pictures of pre and post vitrectomy. Like I said, what you have to do is just a good core vitrectomy. There is actually no need for you to go and remove the membranes and peel off what you do in a diabetic retinopathy. You should not do it, because if you end up with a retinotomy, you're going to convert this 4A into stage 5 ROP. So this is a case where again it was very anteriorly lifted retina, the space was very tight, and we used a 27 gauge vitrectomy, and you could easily go and just cut the traction bands, and at the end of the surgery, if you see this, you should be happy and not feel sad that you have left so much of vitreous membranes there. Now sometimes you see the eyes coming with the 4A and 4B which are active, and obviously you have to do surgery, but then what do you do when these are the two eyes of the same baby? So what we have started doing is bilateral simultaneous vitrectomy, because you can't do one eye, after 2 weeks take the other eye, because it's going to progress to stage 5. And again, the anesthesia risk is high. So this is something which we started doing in 2015, and we have published this. We have done the simultaneous bilateral vitrectomy. And the anatomical and the visual outcome also quite satisfactory compared to what you do in a single eye. And the main thing is endophthalmitis. You don't want to end up with an endophthalmitis doing a bilateral case. But again, you have to talk to the parents, tell them about the risk and the benefits, and you have to prep the other eye like you're doing a separate eye of a new patient. Like if the entire team has to de-scrub, you have to wash again, put the new instrument, the vitrectomy tube and all, and restart the case as if we are doing for a fresh case. And we are doing it now very routinely, and we haven't seen any endophthalmitis. And you have to tell the parents to use separate eye drops, right eye and left eye, mark them, and not to mix them, and wash the hands in between. So now it is accepted globally now, not only for ROP, for many pediatric detachments, you can do a bilateral sequential vitreoretinal surgery. Now coming to stage 5, again it's the same thing. What you have to do is tackle the traction bands. The only problem is it is so anterior that it is stuck to the lens. So there is no much surgical space. So you have to go and do a lensectomy. So this is a case, and you have to go as anterior as in the anterior chamber, like a paracentesis. So this is a 25 gauge system where we are going straight away because there is absolutely no surgical space. Even if you go 0.5 millimeter behind the limbus, you're going to end up doing creating a iatrogenic dialysis. And here the goal is, after doing a vitrectomy, you try to peel this is a posterior capsule. Again, you have to be very careful not to be very aggressive, because very easily you will see the retina also coming out because it is stuck so anteriorly. So once you remove the posterior capsule, you have to make a cruciate incision at the center using whatever. It can be a pick, it can be your trocars, and try to extend it as much as possible in the periphery. And using a bimanual technique. Obviously, I mean, you don't require a biome for this, it's very anterior. So just with the light microscope, it is done, and the maximum of the assistant can use the light probe from outside. And the whole idea is just to relieve the traction as much as possible and try to open up the funnel. And once you open the funnel, you have to be, there are sheets and sheets of vitreous. So it is better to be a little less aggressive, because if you end up having a retinotomy, you cannot settle the retina like you do in the adults, like putting PFCL or fluid exchange and silicone oil. That will be a disaster. And at the end, you can put either Healon or viscoelastic and leave and hope for the best. So this also, we have published the results, and overall success was that time combined stage 3, 4 and 5 was only 15%, the worst being the stage 5, only 14% anatomical success. And what is anatomical success? It's just the posterior pole attached. That we call it anatomical, and the visual outcome is extremely poor. In fact, there are some people say that you should never touch stage 5 because long-term visual outcome is the same as if you don't do a surgery. So like I said, the pre and the post-op, the pale disc, the drag, RP degeneration, and the long-term outcome is extremely poor. So like Dr. Manoj has said, the configuration of the total RD according to the ultrasound, it was open, 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 narrow, a narrow, open, narrow. So what do you do if you don't have an ultrasound? How do you know it's an open funnel? So that is why the ICROP3 came up with the classification of 5A, 5B, 5C, which just shows that if you see the optic disc, that means it's an open configuration. If you don't see an optic disc, it's a closed configuration. And C is with the anterior segment changes, which is an extremely poor prognosis. So you don't really require an ultrasound to see the configuration of this thing. And this is one of the publications by the Japanese group where they have applied this classification in a retrospective manner, and they found it quite useful that the 5A almost had a 90% complete success. We don't see much of 5As. We always see 5B because most of the babies which we do are unscreened, and the parents are referred to us rather than, the parents get to us rather than the pediatricians referring to us. 5B was 40% and 5C was almost 0%. So the staging is quite useful predictor for the anatomical success even for stage 5 ROP. So ROP surgery can be a smooth sailing and it can be quite satisfying, but just we should remember that we are always on the edge of disaster, that at the anterior lens and the posterior retina, and never be overconfident that, I'll be able to do it, because one small mistake and that's going to, change the entire outcome and the life of the child who's going to live there for almost 60 to 70 years. So with conclusion, with modern vitreoretinal surgeries, good visual outcomes and anatomy are possible in ROP and other pediatric VR disease also, but it depends on the time of intervention, anatomy of the posterior pole, amount of anisometropia and amblyopia management. Doing a good ROP surgery is not the end. You have to make the child follows up with the pediatric ophthalmologist, amblyopia management, refractive assessment, and that will be the aim, the end goal. Thank you very much.
Thank you, Dr. Parag, for that excellent